often these infants have very low birth weight infants, or very low birth weight infants, and they have less than 1,500 grams, most cases are associated with enteral feeding, and the cause of the disease really is not definitely known, and really is unknown cause. But some possibility are noted, or some possibility are said that infectious agents may be the cause of the disease, or inflammatory mediators, for example, platelet activating factors, having an important role for accelerating the disease, and having role such as a fuel to the fire. So necrosis and necrophilitis is mostly seen or occur in premature infants, and then increased gestational age. Possibility of the presence of it is decreased. You see this is not a comparison between healthy infants and NEC infants. The healthy infants are full term, but these are most probably are preterm. These have enteral feeding, but this one have breastfeeding. Antibiotic consumption maybe make a situation for presence of NEC. Dysbiosis also may be one of the causes, but in general, NEC causes is unknown. Typical features in gross evaluation or microscopic evaluation is explained in this slide. Typically, in the neck involves the terminal lobe, second and right column, but it can be present in any part of the GI tract. Gross examination of the neck shows some evidence such as distended abdomen, friable and congested intestine. Frankly, the intestine is frankly gangrenous, and intestinal perforation may be evident, may be happened, but accompanying that peritonitis. And the X-ray, in the abdominal X-ray, you see many air fluid levels, and pneumatosis intestinalis is the term that's used in these situations. Pneumatosis intestinalis. Abdominal radiography shows this feature. In microscopic description, you see mucosal or transmural coagulative necrosis, ulceration, bacterial colonization, and submucosal gas bubbles. You see, and the next slide, the pictures of the microscopic elements, mucosal and transmural coagulative necrosis and ulceration, bacterial colonization, and submucosal gas bubbles. You see in this slide in gross examination some submucosal gases, or distended intestinal wall is evident in this photo. And necrotic intestine with some hemorrhagic areas, ulceration, presence of bubbles in mucosa and submucosa. In this photo, you see gross picture, and this one shows you normal histology picture of intestine, necrotizing enterocolitis. Clinical course. About clinical course, it should be said that it can be on the onset of the neck, maybe with bloody stool, abdominal distension, and development of circulatory collapse. Management of this disease in the early phases may be conservative, but 20 to 60% of them lead to operative interventions, and the resection of the necrotic segment of the intestine is with choice treatment. But in general, their prognosis is not good, and high perinatal mortality is evident, and they have some complication after these operations. For example, post-neck strictures and fibrosis can cause some stricture sites in their intestine because of healing process. And okay, this data was about necrotizing enterocolitis. Okay, it's clear. Okay, cells and fetal hydrops are deleted from your titles. I jump into tumors and tumor-like lesions of infancy and childhood.
You don't have the slides before?
They those titles are deleted because I think, in my opinion, these titles is not necessary for you now, and you will study these titles in a stagiary period the next terms. So I want to talk about tumors and tumor-like lesions of infancy and childhood. Two titles that are tumor-like conditions, that they are not really tumors, but they are tumor-like conditions. Hamartomas and choristomas. Do you have any definition about hamartoma?
Hamartoma is when there's tissue which is not organized, but the tissue is the same type of a tissue around it. So for example, lung tissue, the lung but it isn't organized. So maybe you'll have the layers aren't organized and they're separately.
Yeah, exactly. And definition of hamartoma in opposite to choristoma may be better understand. Choristoma means choristoma or heterotopia. Heterotopic. Heterotopia or choristoma. Heterotopia. Okay? Versus hamartoma. Hamartoma means is used when we are talking about a tissue, for example, lung. In the lung, you may some cartilaginous tissue in the lung, for example. For example, cartilaginous tissue or not organized. Disorganized. They are in hamartoma. They are, all of them are present that are related to a native organ line, but they are not organized. They are disorganized. And this definition is about hamartoma. But choristoma is presence of the normal tissue in abnormal location. You see pancreatic tissue,
Intestine.
pancreatic tissue, with organized structure in abnormal location, such as stomach. Okay? We don't expect to see pancreatic tissue in stomach, but and sometimes you see stomach and part of pancreatic tissue with organized structure without any disorganization, but in the stomach. It means heterotopia or choristoma. And these titles are different from each other. You should know the exact definition of them and don't mistake about each other. Okay? You understand?
Yes.
Two special categories of tumor-like lesions. Heterotopia or choristoma refers to microscopically normal cells or tissues that are present in abnormal locations. But hamartoma refers to an excessive multifocal overgrowth of cells and tissues native to the organ in which it occurs. Okay? What about tumoral lesions? Tumoral lesions include benign and malignant tumors. Okay. Tumor means what is the difference between tumor and neoplasm?
Neoplasm, it's just a growth, and maybe it's not necessarily a tumor. For example, warts are neoplasms, but they're not tumors.
Tumors means neoplasms. Neoplasms or tumors may be malignant or
Benign.
benign. So we can use the neoplasm and go with tumor. They are subcategorized to benign and malignant. Okay? And what about cancer?
It's malignant.
All of malignant tumors or malignant neoplasms means cancers. Okay? Cancer means malignant neoplasm. Okay. And in the childhood period, you have some benign tumors, some malignant tumors. Benign tumors include hemangiomas, lymphangiomas, and teratomas. I highlighted them with green color because they are benign. But the malignant tumors include neuroblastomas, retinoblastomas, and Wilms tumor. I highlighted them with red or pink you know Wilms tumor, yeah? Yesterday we talked about Wilms tumor. And today I explain completely about it. Okay, we started about tumors and benign and malignant tumors. You know, malignant neoplasm constitute the second most common cause of death in children between the age of 4 and 14 years. And benign tumors are even more common than cancers. So benign tumors are more common than malignant tumors. You see this picture, pancreatic heterotopia. This part of the picture shows another tissue with picture of stomach, and this part shows pancreatic tissue with organized feature that's present in stomach tissue. So we use the term of heterotopia, pancreatic heterotopia. But this is non-hamartoma. You see disorganized cartilaginous tissue and alveolar structures that are really disorganized, but all of them are native to the lung. Mass formation of these disorganized tissues make a hamartoma, make a structure that's so-called hamartoma. Okay, benign neoplasms includes hemangioma. I think you see hemangioma in practical sessions, okay?
I don't remember.
Practical Miss Hadley said to me that you see hemangioma, colorless hemangioma, and capillary hemangioma in practical sessions.
I don't remember.
Okay. Hemangiomas are the most common neoplasm of infancy. Okay. Most common neoplasm of infancy is hemangioma. Hemangioma may be awareness, hemangioma, and capillary hemangioma, which are differences between them. Colorless hemangioma is composed of some large congested blood vessels that are lined by flattened endothelial cells, okay? And they are full of RBCs. They are really congested. Okay? And intervening stroma between them are really scant, because these large blood vessels are really proliferated, and they are really packed. That's when the stroma is really scant. These large blood vessels are full of RBCs, and endothelial lining are really bland looking, without any atypia or mitotic figure. Okay? Endothelial cells that are lined these large blood vessels. capillary vessels form lobular architecture or lobular pattern. Lobular pattern is an important point to recognize the capillary hemangioma. These vessels are really small sized blood vessels that are proliferated in the blood pattern. Then these types are different specifically. All of them have endothelial cells with gland-looking appearance. There is no incipia or mitotic figure. Okay? You understand?
Yes.
Or not?
No,
You
Yes.
understand? Those covered in capillary hemangiomas are you see this is that covered hemangioma, large spaces filled with blood. Okay, very scant intervening cytoplasm. But in this picture, you see the gross appearance of the covered hemangioma. You see a patch with elevated lesion with this color, with this pink color. And this is a microscopic feature of the covered hemangioma. But this is capillary hemangioma. You see some lobules containing thin bar capillary vessels that are really small size. Their endothelium is really gland-looking without any atypia or mitotic figure. These endothelial cells are gland-looking. This picture is a nodular capillary hemangioma. A gross feature. The gross feature is really different. Maybe different form, different size, different color. The children or hemangiomas are located in the skin, especially in the face and the scalp. Do you know he? Who is he?
I don't know.
Who is he? You don't know him?
No.
Gorbachev.
President of Russia. Was the president of Russia.
Yeah. He has hemangioma on his scalp, and you see multiple features of the hemangioma. It may be flat or maybe elevated, maybe irregular, and different colors, red, blue masses, and some of these lesions that are flat and larger referred to as port wine stains because the resemblance of these lesions to the wine. Okay? Some hemangiomas. What is the fate of hemangiomas? What is the fate of hemangiomas? Hemangiomas may be, most of them spontaneously regress by the age. And this example is an extensive region of the hemangioma in the lower limb of the infant that's spontaneously regressed after 2 years. You see, and this is like a comparative feature. So many of these hemangiomas these are important cosmetic and they have cosmetic significance. So the vast majority of these lesions are operated because of their cosmetic significance, no, because of their dangerous constitution. These are another feature, another schematic feature of the hemangioma in that face that may be different in color or feature with the age. Okay. These contents may be about hemangioma, but about lymphangioma. Lymphangioma also is another benign neoplasm that is a counterpart of hemangioma, and you see proliferation of the lymphatic vessels in the childhood period. Microscopic examination of the lymphangioma shows some dilated blood vessels that are lined by endothelial cells. What's the difference of the lymphangioma with hemangioma? Difference between lymphangioma from hemangioma. In lymphangioma, you see a pale eosinophilic material that filled the vessels, the lymphatic vessels. It's so-called lymph. Pale eosinophilic material or substance. Okay? And there are maybe some RBCs also in the lymphatic vessels, but the important point is presence of is in this pale eosinophilic material that we realize that these vessels are lymphatic. Okay? Some RBCs also may be present, but those ones are full of RBCs. The blood vessels are full of RBCs. Okay, microscopic examinations show cystic and cavernous spaces lined by endothelial cells. Some areas show lymphoid aggregates, and the spaces usually contain pale fluid. They occur on the skin, more importantly in some areas such as mediastinum, axilla, or deeper regions in the neck or retroperitoneum are the locations of the lymphangioma. These tumors also histologically are benign, and indication of the surgery of them also is because of their compressive effects, not because of their malignancy, or they are really benign and they are not dangerous, but they tend to increase in the size after birth, and if they are located in, for example, mediastinal structures, can compress them and may be dangerous. You see lymphangioma and neck of the infant, and is the gross examination of the lymphangioma after cutting the tumor. You see in some RBCs also present, but they are not blood vessels. They are lymphatic vessels that are involved by the classic process. Okay, and the lymphangioma also finished. Please ask me any question if there is some areas unclear.
Also,
And about the last benign neoplasm, teratoma. Teratoma is a tumor that is arised from all of three layers of three embryonal layers: endoderm, ectoderm, and mesoderm. In a teratoma, you may see all of mature tissues, and usually the tissues that you may see in a teratoma may be skin or a part of tooth or hair or cartilage. All of them in mature forms may be present in teratoma. All of tissues that are present in teratoma are mature tissues. And they are really recognizable for you under the microscope. These teratomas, these tissues may be derived from all of three layers of embryonal layer: endoderm, endodermal layer, ectodermal layer, or mesodermal layer. Okay? Arise from all of these three layers. Sometimes in addition to these mature tissues in teratoma, we see some immature components, immature tissues, or components. These immature tissues are not recognizable for us that these tissues are originate from that from which organ. If in addition to mature tissues, immature tissues also present, the name of the trauma or the nomenclature of the trauma is indeterminate potential or immature teratoma. Immature teratoma. Okay? But this one, if we see only mature tissue, means mature teratoma. Okay? Immature components, they seems like undifferentiated tumoral cells with high MC ratio, with unknown origin. Okay? If in addition the teratoma, we have some germ cell tumor component, at least some germ cell tumor component. These teratomas are unequivocally malignant. So we have three types of teratoma: a benign teratoma that are well differentiated cystic lesions, that are so-called mature teratoma, dangerous of them are malignant teratomas that are mixed with germ cell tumors component. Okay? Location of the teratoma. The most common location is sacrococcygeal. 40% or more of cases are located in sacrococcygeal region. 10% of sacrococcygeal teratomas are associated with congenital anomalies. Okay? About 75% of the teratomas are mature teratomas, so are benign, and 20% of them are malignant and can be lethal. And the remainder are immature teratomas that have some amount of immature tissue elements. Most of the benign teratomas are seen in younger infants in less than 4 months of age. The older children have the more malignant lesions in teratoma. Children with malignant lesions tend to be somewhat older. Okay? You see in this slide squamous lining epithelium of the skin that produces some protein material in this part of the picture. In this part of the picture, you see some cartilaginous tissue, and this one is transitional epithelial lining from the urinary bladder bulb, and all of them may be present in mature teratoma. Okay, the benign tumors of the childhood